doing on Wednesdays and Fridays every week. So after our successful first virtual conference, which we did for almost 8 hours for 2 days, and almost 10 speakers, international speakers from America, England, everybody participated. And the speakers from all over India, not only restricted to Bangalore, all over India, they were there. It was one of the successful paid conference. So almost 650 people, they paid and attended our conference. It is one of the best conferences we faced it. All the good remarks were there. And after this, we are coming to, this is our first webinar we are doing after our virtual conference. Thanks to MCure company with the help of Mr. Rajesh. He was there with me since last 2 months, asking, 1.5 months, asking me, sir, we want to do one program, one fantastic program on hemato-oncology. I have got the best speakers with me. I will help you. Why can't we have work together to have one of the best webinars? So accepted, and this is the day we got it. It is an hematology and oncology update for pediatricians. If you see the speakers are spread out all over India from the best centers from India. So whether it is Gangaram or Kokilabin Hospital or my own good friend from Naran Hudayalaya and from Aster, so many best centers and the best speakers are there and giving a nice academic feed on hemato-oncology to us. So on this thing, I welcome Dr. Sunil Bhatt. Dr. Sunil Bhatt, the Director and Clinical Head of the Pediatric Hematology, Oncology and Bone Marrow Transplantation Service, Narayana Health Network Hospitals, and Majumdar Shah Cancer Center at near Narayana Hridayalaya Health City, Bangalore. So I welcome you, and this is the third time we are face to face on computer and discussing about good topics on hematology. Dr. Sunil Bhatt, please, I welcome you and please take over.
So good evening, everyone, and thank you, Dr. Ravi Shankar, for this opportunity to engage with the Pediatric Hematology Oncology team today to discuss some of the very relevant topics. And I think, as you mentioned, we just try to keep some updates today, which is to kind of share with our colleagues, pediatric colleagues, that what's kind of new happening in this field, because we know that hematology oncology field can be challenging. The morbidity and mortality associated with it is something which kind of makes it kind of a little different from others. But I think what we wanted to share with you today is that lots have changed in the last few years. And we just want to bring that and share that with all the colleagues today on this platform. We also try to deliberately keep a session on shared care and also cord blood banking, because there's some of the common questions which we encounter from our pediatric colleagues. Now, as you just mentioned, we have got one of the esteemed faculty from all over India, and I thank each one of them to share their time with us this evening and share their experiences with us. We have covered practically all the corners of India to have these colleagues interact with us today. So with that short remark, I will introduce my friend Dr. Gaurav Kharia to start today's deliberations. We'll have two small talks, and then there will be a more of a panel discussion post that. So Dr. Gaurav Kharia is a senior consultant. He's also the clinical lead of the bone marrow transplant program, and he is a senior consultant in pediatric hematology, oncology, and immunology department at the Apollo hospitals in Delhi. Gaurav is also the treasurer of the Pediatric Hematology Oncology Chapter of India at this point of time. So Gaurav is going to be telling us basically about ALL, acute lymphoblastic leukemia, which is the commonest malignancy seen in children, and he's going to share with us, what we have achieved in this disease in the last few decades, and how the future seems to be. So Gaurav, and that's for me also, I think we'll restrict our talks to 18-20 minutes so that there is some time for the questions as well. Over to you, Gaurav.
Good evening, everyone, and thank you, Sunil, for organizing this nice session. And I would like to thank the Encure team also for their continuous scientific involvement in the scientific sessions which they have done across the country with different people. Just a second. Can you see my slide, my screen?
We can see the screen. Just
see the screen, but it is not in the presentation mode.
Just to do the.
Just a second.
I had to make it in the presentation mode.
It? Can you
Yes.
see?
Yeah, now it is fantastic. We can see it now.
Sure. So, when Sunil called me, he asked me to do a session on recent advances in management of pediatric ALL. Now, ALL, as you all might be aware, it's a huge disease, and each advance which has happened in the field of acute lymphoblastic leukemia, whether it is with respect to diagnosis or with respect to treatment or with respect to staging, I mean, it's a big topic on its own, and it takes a lot of time to cover that. So what I have done today is to briefly cover an overview of pediatric malignancies. What is the incidence, what is the percentage of the leukemias in that group, and then how the treatment has evolved over a period of time. Just give me a second, please. Sorry, excuse me. Sorry, actually my daughter is also having a class, so it becomes difficult. What I'll do is I'll take you through the basics of the pediatric malignancies, and then subsequently we'll move on to the advances which has happened, the journey of the treatment and achievements in pediatric ALL treatment, and what are the current practices in the management of pediatric ALL. So the talk will cover the background, a word about minimal residual disease and how it helps us to guide the treatment, novel diagnostic strategies, existing and novel genomics, the treatment advances which have happened, a word about advances in transplant, immunotherapy, CAR T cell, and then summary of the presentation. So looking at the incidence of pediatric malignancies, if we look at this particular picture, we can see that from 0 to 14 years of age, the commonest malignancy is leukemia. Okay, this is followed by brain tumors, lymphoma, and then other rare tumors. So till 14 years of age, the commonest malignancy, whether it is 0 to 4 years, 5 to 9 years, or 10 to 14 years, it is leukemia. And this is why it becomes a very important treatment for us as pediatric oncologists and for pediatricians as well. If we look at the geographical distribution of pediatric malignancies, then also we can see that in majority of parts of the world, leaving aside some of the African continent where lymphomas are maybe the primary or the most common pediatric malignancies, and rest of the world, it is leukemia, which forms the commonest group of pediatric malignancy in 0 to 14 years of age. Now, as far as coming to the clinical presentation, we know that the acute lymphoblastic leukemia, pediatric acute lymphoblastic leukemia, can have a very variable presentation. Okay, the commonest symptoms are bleeding, manifestations or risk of infection. There is lymphadenopathy, hepatosplenomegaly, vague bone pains, generalized feeling of being unwell. These are the commonest presentations which we encounter. But there might be some other rare complications also, which with which these kids can present. So we always need to have a very high index of suspicion whenever we have a child which is not responding or not fitting into the usual clinical spectrum of the pediatric ailments, viral ailments, bacterial ailments. Then we should have a high index of suspicion for underlying malignancy. Now, I would like to start this presentation with this particular slide, which summarizes the history or the journey of acute lymphoblastic leukemia. So this is a real success story for all of us as pediatric oncologists. And why we say that it is a real success story? Because the outcome has improved from less than 10% to more than 90% within last 5 decades. Okay, so 5 decades back, the outcomes were less than 10%, and nowadays, majority of centers, dedicated centers, majority of trials, they are offering a outcome of more than 90%. How the treatment has evolved for ALL. So this is a picture which very nicely summarizes that how the treatment strategies have evolved for ALL, and how has it led to the success of treatment in ALL. So if we see in 1950s, where primarily a single agent chemotherapy was used, the outcomes were dismal, so almost negligible outcomes. But eventually the concept of chemotherapy, combination chemotherapy, came in 1960s, and the outcomes improved, but still the survival duration improved, but still the long-term survival or lifelong survival was not there. And the oncologists used to see that majority of cases relapsed after some point of time, and majority of relapses happened in CNS. So this gave the emphasis on CNS guided therapy, okay, which happened in 1970s. So with the focus on CNS guided therapies, CNS directed therapy, the long-term survival started improving. This was followed by intensive chemotherapy, combination of intensive chemotherapy, which further improved the outcomes. And then from 1990 onwards, risk-adapted therapy. Now, this is the thing which has led to significant improvement. And nowadays, this figure which shows the outcomes between 70 to 80%, now these outcomes are close to somewhere between 90 to 100% in majority of the trials. A small example can be seen in this pictorial, where the CCG group, Children's Cancer Group and Children's Oncology Group, if we see their trials, which started somewhere in 1960s, the outcomes were very less, close to 10% or even less than that. And gradually, with their ongoing trials and repeated modifications, understanding of the disease biology, addition of treatment strategies, we can see here that in recent years, the outcomes have improved to more than 90%. And this is not only about the Children's Oncology Group or Children's Cancer Group. This is the success which is reflected all over in all the trials, whether it is the BFM trial, which is the German trial, COG, or the French trial, or the American trial, UK trial. So all these groups have reported more or less a similar success rate, which ranges between 85 to 90, 94, 95%. So the success is not limited to one part of the world. It is a global scenario. And I feel very proud to say this, that in majority of the dedicated centers in India also, the outcomes are more or less close to these figures, which we can see here in this slide. So somewhere around 80 to 90%. So looking briefly at ALL, what it is. So ALL is the commonest childhood malignancy. 30%, it forms 30% of the childhood cancers. If we look at the leukemias per se, it forms 75% of the childhood leukemias. The peak age is between 2 to 8 years. Out of the total number of cases, 85% are B-cell malignancies, and around 15% are T-cell malignancies. The treatment, as we have seen, has evolved significantly over the last 5 decades. And this is because of the multi-agent chemotherapy, improved risk stratification, and definitely better supportive care. However, despite significant improvement, there are certain subgroups which still have a very poor outcome, such as infant ALL, ALL relapse, or the patients with high-risk cytogenetics or high-risk genomic alterations. Now, this is something which I will always put my slide, and I always emphasize on that. This sounds like a similar disease, okay? But ALL in adults and ALL in pediatrics is very, very different. And these are the salient features which differentiate these two groups. So the overall survival in pediatric ALL, as we have seen, is more than 90% nowadays, versus adults, where it is still around 40 to 50%. High-risk cytogenetics is more common in adults. Better and more structured protocols are now available for pediatric ALL, thus replicating into better outcomes. A disciplined follow-up and better chemotolerance also adds to improved outcome in pediatric ALL. And the application of pediatric ALL, pediatric type protocols for adolescents and young adults have resulted in significant improvement in outcome in young adults as well as adolescents also. Then coming to measurable residual disease, this is also called as minimal residual disease, but a better terminology is measurable residual disease. The majority of the protocols now, or majority of the groups, follow this as a standard to guide their treatment. So how does this help us? So MRD is the most important predictor of long-term outcomes. It's an amalgamation of disease biology and the patient and treatment related factors. Okay. There are various techniques by which we look for MRD, which is measurable residual disease. It can be measured by flow cytometry, multicolored flow, or it can be measured by polymerase chain reaction or next generation sequencing. And the sensitivity ranges from 1 into 10,000 to 1 into 1 lakh. That means techniques such as flow cytometry can identify one abnormal cancer cell in 10,000 normal cells, whereas techniques like NGS can identify, or PCR can identify 1 in 1 lakh. To add further to this, there are some new techniques such as high throughput sequencing, which has a sensitivity of 1 in 1 million. Okay, so better identification. If we can identify one abnormal cell in 1 million cell, obviously our treatment will be directed or guided in a better way. So MRD guided therapy has significantly improved the outcomes in all the pediatric ALL trials across the globe. Then looking briefly at the novel diagnostics or the genomic analysis. Okay. Now ALL might sound to be one disease, but if we go in depth and analyze the cytogenetics or genetic analysis of any particular ALL, we can we see all these cytogenetic abnormalities. Okay, so some patient might have ETV, which is the commonest mutation. Some might have the pH positivity or some other rare mutations which are shown in this vertical pictorial. Now, how do these help us? So some of these cytogenetic abnormalities are associated with good prognosis, such as hyperdiploidy or ETV rungs, whereas others are associated with poor prognosis. And a very classical example is Philadelphia positivity, which is 922 positivity, MLL gene rearrangement, low hyperdiploidy, and etc. So growing understanding of disease biology allows a better risk stratification and thus helps us in better risk-guided treatment approaches. Okay, and it is assumed that in near future it can be envisioned that ALL will be molecularly characterized and defined, thus enabling us to deliver a more tailored therapy to each patient. Okay, so the future is that each patient might have a tailored therapy for his or her ALL. Okay. Now, how do these novel genomic alterations help us to decide the prognostic, or what is their therapeutic relevance? So, if we look at the left side of this slide, we see these certain some of these mutations. You might have heard of commoner ones such as JAK mutations. Okay, so for example, this is a mutation in which if we know that yes, JAK positive, there is a JAK mutation, we can use JAK inhibitors, and that might help us improve the outcomes. Whereas if you look at others, PAX5, IKZF1, these are known to be associated with poor outcomes. So right from the beginning, we as pediatric oncologists know that this child does not have a poor outcome. We need to be more intensive in our treatment approaches. Okay. And more importantly, we can prognosticate the patient and the family accordingly. Looking briefly at the treatment advances which have happened. So adolescent and young adults, as we have seen in the previous slides also, the outcomes have improved significantly if they are treated on the pediatric protocols. A classical example is the DRAL protocol, where the outcome of patients treated on pediatric protocols was 66% versus 44% treated on adult protocols. And this is the same in multiple other studies, American studies, etc. Ph positive ALL, outcomes have improved from 19% approximately pre-TKI, tyrosine kinase inhibitor era, to more than 60 to 80% currently with the availability of multiple tyrosine kinase inhibitors. There is a common question about when the child goes back to pediatrician after getting the treatment, then that what should be the duration of TKI post-transplant. So the duration of TKIs post-transplant, if the transplant has been done in CR1 for Ph positive ALL, it is around 12 months, and if it is in CR2 or more, then the duration is not clear. So some people use it for 2 years, some 3 years, some say indefinitely. There is an entity pH like ALL, okay, which does not typically behave like Philadelphia positive ALL. Now, there are targeted therapies for this subgroup also, such as mTOR inhibitors, JAK inhibitors, and with this, some of the groups have shown better outcomes. Infant ALL, this, despite the success in the overall pediatric ALL, this still remains a very poor risk group or high risk group with poor outcomes. It forms around 2 to 4%, and the overall survival, despite the best possible treatment, is still around 35%. T-cell ALL, improve outcomes almost similar to the B-cell ALL now. What has helped in this improved outcome is the MID guided therapy, upfront use of nelarabine, which is a very specific drug for T-cell ALL, addition of bortezomib in cases of relapse, and the CAR T-cell therapy, the CD45. We'll briefly discuss about CAR T-cell therapy. What is it all about? Then early precursor T-cell, this is a new entity with molecular heterogeneity. Poor outcomes, ruxolitinib is the drug which helps in this group. MRD guided HR regimens, however, show similar outcomes. In talking briefly about recent advances in hematopoietic stem cell transplant. Now, this is a very important strategy to treat these pediatric ALL. However, majority of patients do well just with chemotherapy, but there is a small percentage, I would say around 10 to 20% of the patients who need HSCT, hematopoietic stem cell transplant. Now, earlier, there were a number of limitations that the donors were just matched sibling donors or alternative donors. Matched generated donors were very uncommon, but the progress which has been made in past 2 to 3 decades, the donor is not a problem now, irrespective of the donor, whether it is a full match sibling donor or an unrelated donor or a half matched family donor, the outcomes are more or less the same. Okay, and the techniques which we have to offer better outcomes are now very, very sophisticated techniques. The picture shows one of the latest techniques where you can selectively take out the cells, harmful cells in haploidentical transplant, and preserve the cells which are useful for the patient. Then immune targeting. So ALL is an excellent candidate for monoclonal antibody therapy due to the constant lineage specific antigen expression on the blast, on the cancer cells only. And this expression is not there on the normal tissues. So immunotherapy has this advantage that it specifically targets the cancer cells, but does not damage the normal tissues, which is different from the conventional chemotherapy, which apart from damaging the cancer cells, also damages the normal tissue. It has high remission rates, and as I said, non-overlapping manageable toxicity. Some classical examples which are available now: blinatumomab, inotuzumab, alemtuzumab, rituximab, and so on and so forth. So these are the drugs which are used for relapse refractory settings, and some people have even started using it as upfront in newly diagnosed ALL. This picture shows these two main drugs which are available with us now, immune therapies. One is blina, and another one is inotuzumab. I'll not go into much details, but I'll just briefly explain how it works. So this is a bispecific T-cell engager. So this, at one end it binds the CD3, and at other it binds the B cell. So with this bonding, it somehow activates the perforin and perforin granzyme pathway, and with this it causes the lysis or apoptosis of the cancer infected B cells. So this is how blina works. Inotuzumab is a anti-CD22 specific antibody, and it is attached to this calcineurin. Now, this is initially in active form. Once it enters the cell, it activates, and it has this potential of damaging the DNA within the cancer cell. So this is very specific drugs. So they just cause damage to the cancer cells, but does not harm too much the normal tissues. Coming to CAR T cell therapy, this is a new driving force. It is used primarily for relapsed refractory settings, which is still a leading cause of childhood cancer mortality. Relapsed ALL has a dismal prognosis, irrespective of what chemotherapy we use. CAR T cell therapy has brought a paradigm shift in the relapsed refractory ALL treatment. This attractive therapy harnesses the immune system of the host to eradicate the leukemic clone. T cell therapy involves injuring T cell receptors to bind specific antigen present on the tumor cell. We'll see how it works. So if we look at this picture, so the T cells are genetically modified so that their receptors is able to identify tumor specific antigen, and by this way, once it identifies the tumor specific antigen, it causes the replication of these T cells, and then it can cause the lysis of the cancer cell. Okay. Now, once the CAR T cell therapy started, it was identified that it has certain lacuna. The proliferation of these cells was not optimal, so modifications were made to these CARs, and then came in picture the second generation CARs or the third generation CARs, which are very effective nowadays in treating these high risk relapsed refractory ALLs. So to summarize, ALL is the commonest pediatric cancer till 14 years of age. It can have variable presentation. So we need to have, as pediatricians, we need to have a high index of suspicion. Treatment outcomes have improved to greater than 90% on most of the protocols. And this makes it a true success story. Risk-adapted therapy, targeted drugs, and better supportive care have also contributed significantly to better outcomes. Cancer immunotherapy is emerging in a big way, and CAR T cell therapy, as we have just seen, for refractory setting has brought a paradigm shift in the treatment of pediatric ALL, relapsed refractory pediatric ALL. With this, I'd like to thank you for a patient hearing, and I'll be happy to take questions whenever Sunil permits. Thank you.
Thank you very much, Gaurav, for this excellent overview. I think you covered, probably every bit of it in a very short span of time. So I think, to summarize for our pediatric colleagues, as Gaurav said, the most common malignancy presentations can be very variable, but very important to notice that these kids can present with joint pains, musculoskeletal manifestations. So there's something which we really need to suspect if children are coming with that, and before starting any steroids or anti-inflammatory medications, it's better to rule out leukemia as a manifestation. What you also try to show us that the diagnosis of ALL has evolved over a period of time, and we have got now very good robust diagnostic modalities in addition to bone marrow, which helps us in correct stratification of the disease. Treatment is very effective and can cure more than 85 to 90% patients. And treatments are also now tailored as per the type of ALL based on the diagnostic evaluation which you have got. So in current era, probably, no child with ALL should go without treatment. And what you also try to show us is that the treatments have evolved beyond chemotherapy to more of immunotherapy or targeted therapy, which is supposed to have less side effects as compared to the conventional chemotherapy. And there is a subgroup of patients, which may be less than 10 to 20% of the patients, who may need non-chemotherapy based treatments like bone marrow transplant or newer immunotherapies like CAR T therapy. So what he showed. So I think pediatricians play a very important role in the shared care of ALLs, because chemotherapy is only for 4 to 5 months, which is intensive chemotherapy. Post that, they take just simple chemotherapy tablets, which is 6-MP methotrexate, and that's where pediatricians are also engaged in helping in monitoring these patients, and also, of course, at the diagnosis, counsel those families to continue and seek treatment, because as he already showed is that the cure rates can be as high as 90%. So that was the overview of his talk. So Dr. Ravi Shankar, do we have any question? What is the format of questions on this? It's on the chat box, it will come, or we'll do at the last? You have to unmute yourself.
It is there in the chat box, which you already
Okay.
answered, but
Okay.
somebody had suggested please answer it openly instead of answering on the chat box they're asking. That's why.
Sure. So one question, Gaurav, was that, in ALLs, what about adolescents, children who are adolescent, how do they do? Although we answered it in the chat box, but you can probably explain.
So adolescents, actually, if we treat them on adults, so this is a group which can fit into the pediatrics also, or the with the adult oncologists also. World over, it has been seen that the adolescents and young adults who are treated on pediatric protocols, they do much better. So suppose if we have a young patient of around 20-22 years of age with T-cell ALL, if we treat this particular patient on one of the decided pediatric protocols, whether it is the BFM group or the UKLL, the outcomes will be much better as compared to the treatment on any of the adult protocols. So there are different adult protocols as well. Okay.
Thank you.
Call you back. I'll call you back.
So Dr. Ravi Shankar, I think that's it from the first session. So over to you.
You can go ahead. No issues at all.
So we'll go to the next talk. I think we'll go to the next talk that I am going to take on recent advances in thalassemia. So if you could stop sharing screen, Mandar, I can share mine. Yeah, thank you. So this is another topic, which we were asked to discuss today, and as you'll all agree with me that this is one of the common diseases which we all encounter in the hematology oncology scenario in Indian settings. We are the thalassemia capital of the world. Maximum children born with thalassemia in India. We had about 25 to 30,000 children, both with thalassemia major and thalassemia intermedia in our country every year. And most of these patients are managed by pediatricians with interest in thalassemia, or otherwise also in centers which have transfusion facilities in medical colleges. So I think it's a very common and important disease which we encounter in our practice, both in hematology oncology as well in general pediatric practice. So first of all, when we talk about thalassemia, we know it's a multi-system disease, and hence a comprehensive teamwork is required, which is not only required for diagnosis but also for the correct blood transfusion, the correct iron chelation, management of complications which are endocrine, cardiac, and others. And then we also have some newer treatments available, and that we can discuss in the recent advances, which is kind of the topic for today. And also we have to remember that there has to be a preventive strategy also in the prevention of thalassemia major, and that ranges from antenatal diagnosis to pre-marriage counseling and others. Now, before, this is the outline of my talk, although this is recent advances, and we'll discuss some recent advances in pharmacological treatments available, gene therapy, combination chelation therapy. But before we go into that, this is a very important cartoon. This kind of tells us what are the different therapies which are available in thalassemia world. The most important, and that's still the kind of the focus of today's talk, and also otherwise, is conventional therapies. So there are two important therapies, and that one is Paxil transfusion and one is iron chelation to reduce the iron overload. However, nowadays we also have newer agents, which are the new pharmacological agents, and we'll discuss them in a little bit of more detail. Then we can have curative options. The curative option is to cure this forever, and there are two potential curative options: a bone marrow transplant, which has been there for decades, and then which is fast catching these days is something called a gene therapy. Now, what about transfusion therapy in thalassemia? Transfusion still remains the hallmark of thalassemia care. And, what's very important, which is one of the messages I want to convey here today, is that we have to maintain a pre-transfusion hemoglobin. So before they get transfusion at the transfusion centers, pre-transfusion hemoglobin should be maintained between 9.5 to 10.5 gram%. Because if we do that, the mean hemoglobin would be maintained around more than 12, and that is the physiological hemoglobin in our body. If a child is maintained at a lower hemoglobin, although there may not be too much symptomatology because it's a chronic anemia, but lower hemoglobin levels less than 9, if it's maintained pre-transfusion, these children will develop hemolytic phases. These will develop organomegaly, liver and hepatomegaly, liver enlargement, spleen enlargement, and also bony changes. And that is, indirectly in the later on, it also leads to a higher, iron overload. So I think this is the first message I want to convey here, is that please maintain hemoglobin level of all these kids between 9.5 to 10.5 gram, and that is pre-transfusion hemoglobin levels. Sometimes we do maintain higher hemoglobin levels, so what's called as hypertransfusion or supertransfusion, maybe more than 12 grams, when especially they have high, big spleens, splenomegaly, and you can give them hypertransfusion to bring down the size of the spleen quickly. We also do it sometimes before bone marrow transplantation. But in a general, statement is that unless otherwise, you have to keep their hemoglobin between 9.5 to 10.5, and that has to be packed cell only. So which transfusion to give? It has to be packed cell transfusion only, because we don't require plasma, we don't require white cells to be given in these patients. That leads to higher risk of reactions. And so, the packed cell is only to be prescribed. Now, how much packed cell can be given? 15 ml per kg at one sitting. This is another, kind of, I would say, myth or a misconception that we should give only 1 unit at one time. I think we have to calculate it as per ml per kg at one time. A 10-kilo child will have only 150 ml of packed cells at one given point of time. A 30-kilo child can have 450 ml of packed cells and at one setting. And for how long we have to give this is for 4 hours. We should not hang a unit of packed cells for more than 4 hours when it's to be transfused to the patient, because when it's kept more than 4 hours outside the refrigerator, the quality of blood deteriorates, and then they get more reactions due to cytokine release in the blood. So 15 ml per kg of packed cells over 4 hours. Now we know that infection is a risk due to blood transfusion. So all the blood which is given to them has to be tested. Preferably, we know that ELISA is something which is still commonly used. It's still a gold standard, and has to be performed. But I know some centers offer NAT testing also, which is probably a little better than ELISA and can shorten this period of what you call as window period, and the risk of infections with these multiple transfusions can be minimized. Now, the third important aspect with the packed cell transfusion is getting rid of the white cells in the blood. These white cells which are in the blood, when it goes to the patient, it leads to two important problems. One is allergic reactions, and second, something called as sensitization. So we don't want these patients to get sensitized to these white cells, and also we don't want the reactions to these patients. So hence, white cells need to be removed, and that's called as leukocyte filtration. This leukocyte filtration, can be done by different ways: a simple centrifugation, something called as saline washing. But the best way to do that, leukocyte filtration is by third generation leukocyte filters. And these filters remove 99.9% of the white cells from the blood. And this leukocyte filtration can happen at the bedside. And these are these small filters which are attached to the blood, at the bedside. Or this can also be done in the blood bank immediately before storage. So once you're taking the blood from the donor, you do the leukocyte filtration before storage, and then store the blood. And that probably is better than doing it bedside. But if that is not available, still, if you do it bedside, is still good enough, because 99.9% of the white cells can be removed. So this is the only effective way of doing the appropriate what you call this appropriate appropriate is the leukocyte filtration. Now, that was about blood transfusion. The second important problem which we encounter in these patients with thalassemia is iron overload. And iron overload is because of the multiple transfusions which they are getting every few weeks. The good old standard is ferritin and still is recommended for follow-up. Now in ferritin, there are 2 or 3 problems. One is that there's a lot of inter-lab variation. So the one message I want to convey today is that please do ferritins from the same lab every time so that you have got a good correlation in the same lab. Second is that please ask for a value, because we have seen some of the reports which come as more than 1,500, more than 2,000, more than 2,500. That doesn't give the exact value. So we have to tell the labs to give the exact value of ferritin. The third important thing is that ferritin is an acute phase reactant. So any infection, any fever, any cough, cold can increase the ferritin fallaciously. So if a patient is unwell, if a thalassemia kid is unwell with any of these, we should wait for the illness to settle down and then do a ferritin. There should be a good at least 2 weeks gap delay between acute illness and a ferritin estimation, because it can be fallacious. Now, to overcome all these problems of what we call this, of the ferritin estimation, iron oral estimation by ferritin, which can be overcome by, which is called as MRI. So we can do T2 star MRI of the liver and the heart and get the exact estimation of iron in these patients. And it is recommended as a modality of choice for iron estimation. And it should be started in children more than 8 years of age, and then to be followed up once every 1 or 2 years, and that gives an exact estimation of iron overload. So that was about iron overload and how do we measure it. Now, what are the treatment options? And more so in the curative option point of view. First is bone marrow transplantation. We all know that bone marrow transplant is effective treatment. It replaces the defective cells in this thalassemia clone and then replaces them with the normal cells. Now, this thalassemia transplant has been going on for a long time. I think Italians have the highest experience of doing transplants in thalassemia. This is their oldest data set, wherein they transplanted almost 900 patients from 1 to 35 years of age, starting from 1981. What they showed is that in their data set is that almost 73% of the patients, even after follow-up of 20 years, could be cured. What they also showed is that the patients who did not have transplant, either they didn't have a donor who got transplanted, or they couldn't, they didn't agree for a transplant. At a 10-year follow-up, if you see here, less than 20% patients were surviving. This is a little older data set. The things are a little better now, both in the context of transplant outcomes and also in the context of, without transplants, patients do better these days with better support to cure. But this was kind of proof of a principle that with transplant, majority of the patients can have long-term cure and majority of the patients can be cured. But what they also showed in their data set is that thalassemia is not one disease when we go for transplantation. Those patients who are low risk, no hepatomegaly, no portal fibrosis, and they're irregularly chelated, those are the good risk ones. The ones who have got big liver, portal fibrosis, they're very irregularly chelated. This is the class 3 or the high risk ones, and something which is in between is called as class 2 or intermediate risk. This was important because what they showed is that the class 1s or the low risk patients, more than 90% of the patients could be cured in their experience. And in the intermediate risk or the class 2s, about 85 to 86% patients could be cured with the bone marrow transplantation, and the outcomes were inferior in the class 3 or the high risk class, wherein the cure rates were in the range of 70, 75, 78% odd. So this I'm trying to show you because I think that, even with transplantation, the outcomes can be so variable depending on what condition the patient is before transplantation. So we should, one, ensure that these patients are well transfused when chelated, because their outcomes post transplantation are heavily dependent on that. And also, if a patient is referred for a transplantation and is not in a good clinical a condition at that point of time, we can work on this child for months or years together to get him in a better better risk categorization before we transplant. Now, what has been experienced wherever of more than 1,200 transplants in our hospital with thalassemia? 18 patients were class 1 patients. And if we see only one rejection out of these 18 patients, and that, almost 95% patients could be cured in one go. The patient who rejected also had a repeat transplant and was cured of his thalassemia. But when you look at class 2 and class 3s, about 135 odd patients. This is a little older slide. In fact, the numbers have gone up a little more now. But if you look at these, this is what is our problem in India. We get patients quite advanced. When you look at the Western data, Italian data, they will have the other way around. There'll be 120, 130 patient class 1s and maybe few of them class 2, class 3s. But we see the data other way around. a 135 odd patient, and if you see their outcomes, which is definitely 85-86%, which is again, although the same showed by Italian experience, but then it's definitely inferior to the class 1 patient. So the message here is that we need to maintain them well, both in terms of transfusion, iron chelation, because their outcomes post-transplant would be different. I think Gaurav touched this a little bit, and that is, if you don't have a fully matched donor in the family to donate for you, you can have unrelated donor as an option. We can also have nowadays we can also do transplant using one of the parents as an option who are half matched. And with that, this is our, one of the experience we had presented a couple of years ago, and still with this half matched transplantation donors, about 90% of the patients could be cured of their thalassemia. So this is something new which can be offered to these patients who do not have a fully matched donor in their family. So to conclude, in thalassemia major, transplantation today remains the only, not only probably, because this probably will change with the gene therapy fast catching, but probably most practical definitive curative option in our country at this point of time. And the cure rates can range from 90, from 75 to 80% or to about 95%, depending on what class of disease or what risk of disease they are before transplanting. Now, there are some challenges posed in this by COVID. I just put this slide deliberately because we're in the COVID era that, we are the risk to the patients, because they're immunocompromised, we presume would be higher due to COVID. The donor status is also important, when they are taken as donors for the transplantation. Unrelated donor transplants are not happening much, and the availability of blood components is a problem during these timings. Staffing is an issue. Some of the people, even the staff is getting infected. So there are a lot of challenges by lockdown and follow-ups and other things. So hence, thalassemia not being probably an emergency transplant. So I think the thalassemia transplant have drastically come down in the current epidemic, and I'm sure in the next few months the activity in the thalassemia world is also going to go up once the situation comes a little bit better. Now, that was about transplant, which is kind of defined therapy and has been time tested, and they're there for the last 30-40 years. What about newer treatments in thalassemia? What about emerging therapies? These emerging therapies are usually are 3 or 4-fold. One is, how do we induce HbF or fetal hemoglobin, and I'll explain it a little bit later about that. What are the newer molecules which help it in effective erythropoiesis? There's something called as hepcidin. I won't touch it too much, but then this is also something which can be used, and also some strategies which can increase the alpha chain synthesis in these thalassemia patients. So this is basically what I was shown in the previous slide. Some of these treatments work in the bone marrow in a very, very premature stem cell stage. Some of them kind of work later on in the mature, erythrocyte maturation phase. Now, there are a couple of these drugs which are new. I don't want you to get the details of this. Something called a JAK2 inhibitor. In thalassemia, what we see that there is a lot of JAK2 expression, and that leads to apoptosis because there's upregulation of JAK2. And if we have a molecule which can inhibit JAK2, what will happen is that this correction will be done, and there will be less ineffective erythropoiesis, and the maturation into the mature red cells would be restored. And this has been tried in thalassemia patients, and this was one of the studies which when it got tried, so they used this drug called ruxolitinib, which is a JAK2 inhibitor in these patients of thalassemia, and what they could show that the majority of the patients, there was a reduction in the blood requirement. Also, their spleen sizes had reduced. So that is one drug which can reduce the requirement of blood in these thalassemia patients. The second drug which has also been tried is called Sept. And there's been a lot of interest in this drug for last many years. What it does is that it again inhibits something called as TGF beta, and it also helps in erythroid maturation in the bone marrow. And this again has been tried in a multi-center study from all over the world. And what it showed is that it was a placebo-controlled study. They tried luspatercept every 3 weeks versus the placebo. This is a subcutaneous injection, and what they showed is that almost 50% of the patient, this is about 300 odd patients, 220 in luspatercept arm and 110 in placebo arm. What they could show in the study is that about 50% of the patients, the requirement of blood had reduced more than 33%. So the transfusion requirement had drastically come down and the reduction was more than 33%. So this is really these two molecules. This is again the same study which showed the reduction in the requirement of blood in these patients. So this had led to the approval of Sept. It has been FDA approved now and is available to be used in these patients, as I said, subcutaneously once in 3 weeks. So what I showed that in the previous slides was that there are two molecules, ruxolitinib and luspatercept, which can be used to reduce the requirement of blood in these thalassemia patients. They don't cure the problem, but they reduce the requirement of blood in thalassemia patients by correcting their ineffective erythropoiesis. Now, there's something also called as gene therapy now, which is very, very interesting. And I get a lot of questions, not only from the families, but also a lot of pediatricians and colleagues who are looking after thalassemia patients in various parts of our state and elsewhere. Now, gene therapy is basically, can be done by two ways. One is using viral vectors, and one is something called as gene editing. It's exactly like transplant. What happens in transplant is exactly what we do in gene therapy. The only difference is that in gene therapy, you're correcting the stem cells of the patient itself. You're not using stem cells from someone else. You're using patient stem cells, collecting them and giving it back to the patient. Now it does employ chemotherapy as in transplantation, but because they're patient's own cells, there will be no immunosuppression. There'll be no graft versus host disease. And because your patient's own cells are being used, there is no problem of donor, whether donor is available or not available. So that gives a little edge to gene therapy or transplant as a curative option. Now, what you do basically is that you take the stem cells from the patient, which is exactly like what you do for a transplant process. You're taking the stem cells out. You have transduced these with the gene. So you used, a viral vector and corrected the gene. And this is the corrected gene which has been put into this, put in the stem cell. And then this goes back into the vein of the patient, reinfusion after some chemotherapy is given to the patient, and then it goes back to the patient, and then settles in the bone marrow. The new cells set in the bone marrow and lead to a healthy bone marrow after that. Now, there are various studies on gene therapy which have been done, both phase 1, phase 2, and phase 3. These are typically called as North Star studies. What they showed is, again, the same cartoon. They collected the stem cells of the patient. They used chemotherapy to destroy their original bone marrow. Then these cells were modified by the virus, and corrected gene was put in them, and then the cells were infused back into the patient, and then they lead to what they call as normal hematopoiesis after the infusion of these cells into the bone marrow. This has been tried, as I said, in few studies. If you see this initial result, which was 204-205 study, 15 out of 22 patients did not require any blood after this gene therapy. So almost 60% patients could be cured with this gene therapy, and they did not require any more blood. If we look at the other studies which came after that, it was a little better outcomes. 13 out of 14 patients did not receive any blood after they received the gene therapy. This was the next trial, 207 trial. So what I'm trying to say in short, this is the gene therapy product called Zynteglo. Bluebird Bio is the company which makes it, and again, it has been approved as a treatment option for thalassemia in Europe and is available for these patients. So in short, gene therapy is catching very fast. Majority of the patients can be cured with gene therapy. Of course, cost is still a concern and still is not available in India at this point of time. Now, this gene therapy can also be done by something called a gene editing, where you don't use viral vectors, but you can do CRISPR-based correction of the gene, and then you again the same process would be there. You take the stem cells out, you modify these genes by using CRISPR technology and give the modified cells back to the patient. Now, this is the last kind of component of my talk today, that is combination of chelation. This is again a very important question which a lot of our pediatric colleagues ask. We know that we have got 3 iron chelators: desferoxamine, which is given IV or is called as Desferal. We have got deferiprone, which is Calfa, and we've got Desfersirox. We have various brand names that are available in India. So, patients, we come across patients where, persistently high ferritin values are there. And if you do MRI, they have got a very high iron overload. They may have significant cardiac disease like cardiac arrhythmias, poor cardiac functions. And sometimes prior to bone marrow transplantation, you need their rapid iron overload reversal. In these situations, if your iron chelator is not enough, it's not working enough, and or the patients have come quite advanced with a good, severe iron overload, can we use 2 chelators at one point of time? And the answer to that is yes. There are various ways we can use these chelators in combination, something called as alternating and something called as combined. Alternating means you have given for 7 days a week, for example, you give one chelator for a few days, another chelator for a few days. For example, you have given Deserol for 4 days and Differential for 3 days. That's called alternating combination chelation. Something called as combined, that means you use both the iron chelators on the same day. For example, desferoxamine, Deserol is also used, and Calfer is also used on the same day. That's called as combined chelation. What has been shown is that alternating, probably not to that extent, but combined chelation does work, and using a combination of any combination is possible. Desferoxamine with Deferiprone, which is Calfer, is the most common combination which has been tried, and there's a lot of maximum literature on it, especially important when there's a severe cardiac iron overload. But other combinations, which is Deferoxamine and Deferserox, and also 2 oral iron chelators, Deferserox and Deferiprone, is data for all of them is available and can be tried if the patient is not responding to one iron chelator, and they beautifully work together when used in combination. And now there's also something called as film coated tablets of Deferserox. It's available in India. Again, it's available in India now. We know that our good old Deferserox, which is available for so many years now, we have to use it empty stomach with water or juice, and it has to be given empty stomach. So a lot of kids do not like that, and they're intolerant to that. So what we can do with this new entry coated formulation is that it's a tablet. It can be used, it can be swallowed. It can be used after meals, so it doesn't need to be necessarily given empty stomach, and it has got better tolerability, and that can be used as well if the patient is not responding to. Now there's something called as Hpf inducers. We know from our knowledge of thalassemia that what happens in thalassemia is an imbalance between alpha and beta chains. There's a lot of alpha chains being produced and beta chains are not being produced because there is a defect in the beta globin gene. Now, if somehow the HPF, the fetal hemoglobin, is induced, or the level is increased, this imbalance will be reduced. So the alpha chain can combine with the gamma chain and give rise to HbF instead of HbA, which is the adult hemoglobin. So various strategies have been used which can increase the level of gamma chain and reduce the imbalance, and hence correct anemia and reduce the requirement of transfusion. The standard or the most commonly drug used in this setting is called hydroxyurea, which has been used in sickle cell anemia and also in thalassemia, especially in thalassemia intermedia. But there are other hypomethylating agents and other drugs which are listed here, azacitidine, short chain fatty acids, Thaldomite, which is kind of being explored at this point of time. So these are other drugs which can be used and that can help in reducing this this imbalance and help to increase the HbF levels, and can be also be useful in reducing the blood requirement. So to conclude, in thalassemia, I think there's a really exciting times which are there. There's a new era of novel therapeutics at this point of time in thalassemia world. Several targets have been identified which can correct probably not only genetic defect, which we can do with gene therapy, but also ineffective erythropoiesis or iron dysregulation, which are important, pathophysiological aspects of thalassemia as well. And number of these targets which have been identified have got, agents which can be used. And these are, some of them are in clinical development, some are they're already been approved, as I showed you in the previous slides. And so, using these therapies either as single therapies or combinations can be really used to minimize the morbidity, mortality in these group of patients. And as I said earlier, a substantial group of patients can be cured with one of these modalities which are available at this point of time. So with that, I conclude my presentation, and if there are any questions in the chat box, then we can take them for answering. Thank you for your attention. Stem cells from patient, how it will be available in grown-up child. So I think there's a question. Am I audible?
Yes, sir, you are audible.
Okay, so there's a question in the chat box that stem cells from a patient, how will be available in a grown-up child. So I think if I rephrase this question, probably the question is that in a grown-up child, how to get stem cells. So stem cells are there in our bone marrow. And these are the precursors for hematopoietic, hematopoiesis, which lead to, give to red cells, platelets, white cells. Now these stem cells can be we can procure these stem cells by 3 different ways. One is to do a bone marrow harvest. That means you go into the bone marrow of the patient and take the bone marrow out, which will have these stem cells. Second is called as peripheral stem cell collection. That means you have given a GCSF, a growth factor to these patients / donors, and the number of stem cells from the bone marrow will be increased, and those will go to the peripheral blood, and from the blood you can collect them in a machine which is exactly like a platelet apheresis machine. And the third one is, from the cord blood. When a baby is born, the cord blood can be stored. It's got a good number of stem cells, and we've got a session on cord blood storage also today. Now, in the context of thalassemia, if you're asking this question, for a gene therapy, for example, so you can correct these stem cells from the patient, thalassemia patient, either from the bone marrow or from the peripheral blood after GCSF. And these stem cells, when they're taken out, these are modified by correcting the gene in them, either through the viral vectors, which I explained there, or through what's called a gene editing. And these stem cells will be put back into the patient through the vein, and these stem cells will go into the patient's body, settle in the bone marrow, and they'll start making new corrected hemoglobin and correct thalassemia in the patient. So that was, I think, that answer to that question. So I suppose there are no more questions. So we'll go to the last session of today's session, last topic of today's session, and that is a panel discussion. I'll introduce, my friend and colleague, Dr. Shantanu Sen, who is a head and senior consultant of pediatric hematology oncology at Kokolaben Dhirubhai Ambani Hospital in Mumbai. He has got a vast experience in hematological oncology conditions. He has got special interest in bone marrow transplant. So Dr. Shantanu, welcome and thank you for your time. And I request you to introduce the esteemed panel you have today, and also take us to the next 30-35 minutes and discuss some of the common, probably entities and topics which are relevant in pediatric practice. And I request probably, I take the privilege of requesting everyone to be sharp and crisp so that we can cover more ground in the next 30-35 minutes. Over to you, Shantanu.
All right. Thanks very much, Sunil, for that great introduction. Let me just try and see if I can share my screen. Could Bandar stop sharing this screen, please? Yes.
Yeah, sure.
Can you give me 1 second? Great. So that was the remit of my talk, to have a case-based panel discussion and touching upon oncological emergencies, a little bit about shared care in practice, and also touch upon cord blood cell banking. And we've got roughly about half an hour to cover, which is really a huge length and breadth of oncology. So we'll try and move forward. Now, my job has become very easy. I mean, to be honest, if I were faced by this humongous task to talk about emergencies in pediatric oncology shared care, I probably would lose my sleep completely. However, I have my colleagues to help me. I've got Dr. Vikas Dua, who's the head of hematology oncology and stem cell transplant at Fortis Medical Research Institute in Gurgaon. And I welcome Dr. Vikas Dua to this group. I have Dr. Stalin Ram Prakash, who's my colleague and friend from Bangalore, and he works at the Aster CMI Hospital. I have another close friend, Dr. Manas Kalra. Just a second, my screen just went away. Yeah, Dr. Manas Kalra at Gangaram Hospital. He's also a very well-renowned pediatric hematologist, oncologist at Gangaram. And then I have my colleague from Bombay, Dr. Ruchira Mishra, who looks after stem cell transplants and pediatric hematology oncology at the SRCC hospital here. I think Dr. Arpita is busy tonight.
Arpita may not be able to join. She's stuck in the hospital. Yeah.
Correct.
So,
and I think Satyendra also has had a family emergency. So unfortunately, he's also not been able to join us. But I mean, with such a plethora of experts here, I don't think we would have much of a problem, even though they would be missed. So, I thought we'll start off with oncological emergencies first, and I have a small case vignette to share with you all. So this is a 4-year-old boy who was admitted to the pediatric unit with a history that he's been having a fever, a low-grade fever for the past 2 months. This, together with the fever, it was noted that he was having a progressively increasing tummy distension. The abdomen was getting bigger and bigger, and that has been for the past 3 weeks. He was not eating as well as before. He has had some occasional vomiting, and it seemed that he was finding it increasingly difficult to breathe. There were episodes when he would be panting very hard. On evaluation by the doctors, it was found that he was pale, he had severe pallor, there was mild icterus, was a bit jaundiced, and he was breathing fast. It was also noticed that he had a rash, a petechial rash over his trunk and limbs, and he had subconjunctival hemorrhages. And of course, when we palpated his tummy, we found the reason why he was having abdominal distension, because he had a massive hepatosplenomegaly. So put that together, young boy, 4-year-old, fever for the last 2 months, low grade, abdominal distension, shortness of breath, and on examination, we got mild icterus, pallor, tachypnea, petechial hemorrhages, hepatosplenomegaly. So as we would all do, first test to do, we'd run a CBC, and this is what the CBC showed. We had a hemoglobin of 5 gram%, a white cell count of 113,000, and the differentials showed lymphocytes of 89%, neutrophils of 4%, with the low platelets. At that point of time, it was 32,000. We asked for an X-ray, and this is what the X-ray is. I have my panelists. Could somebody talk to me about this X-ray and say what we are seeing here? Vikas, if I might ask for your help.
Sure, Shantanu. All right, so it looks as if there is a big mediastinal mass which has been there, and because of the background of fever, abdominal distension, and a CBC which is showing a low hemoglobin, I would say low platelets and a high WBC count of 113,000, it looks as if we are dealing with a case of leukemia with probably a anterior mediastinal mass which has been there in this case.
Absolutely. So that's exactly. So basically what we have is, this is what for us all would be an oncological emergency. We have a high white cell count. We heard the count of being about 130 odd thousand, and we have a mediastinal mass. Because to ask you again, so if we have this together in a patient, what can go wrong when we have this? What are the things we need to do?
All right, so as we are suspecting it to be an anterior mediastinal mass and with a background of fever, hepatosplenomegaly, a CBC showing a low hemoglobin, low platelets, and a high white cell count. So we feel that there is a nodal mass which is there in the mediastinum, anterior mediastinum, and that might be probably compressing the airways, and because of that, the patient might be breathless, might be having difficulty in breathing, and he might also be having superior vena cava syndrome because of the compression of the superior vena cava, which might lead to swelling of the face and probably the petechial hemorrhages which are there in the eyes.
Absolutely.
And because of that, he can suddenly deteriorate. So it's an oncological emergency.
Absolutely. Stalin, how would you proceed when you have this kind of a history and you have this patient in your hospital? What would you do? Dr. Stalin Ramprakash, do we have him?
Yes, sorry, my mic was muted. So thanks for the question. I think this child, as Dr. Vikas has already pointed out, there are so many things which can go wrong. If there is a breathing difficulty, the child will spontaneously assume the right position if the child is conscious. So better not to disturb the child and force the child into any position. If there is a superior mediastinal syndrome type situation, then how much IV fluids we give and where we give is important. Sometimes it may be better to give it through the lower part of the body rather than pushing a lot of fluids through the arms and other things, which will increase the congestion. And if the child is having significant breathing difficulty or the saturation is low, we may have to put the child on oxygen. If we have a facility of Heliox, this is really wonderful in such situations where without giving any further thing, you can reduce the airway resistance and maintain the oxygenation level. and there is a high risk of tumor lysis. So all that is important, and the most important thing is there is always a temptation to go for a CT and do a sedation. This is a kind of situation where you should try to avoid it, and because there is a likely anterior mediastinal mass, you put the child on supine position and give some sedation, all the muscle tone goes away, and it can lead to severe compression. And because the compression is far down, even intubation may not help, and you may suddenly lose the cardiac output. So these are the kind of precautions we need to take. And in addition, there may be some bleeding. Hemoglobin blood transfusion, we have to try and avoid. We don't want to overshoot it. So the most important thing here would be to make sure the child is stable and try to get the diagnosis as quickly as possible so that we can start directed treatment.
Correct. So basically what we have is that somebody who comes in like this, it's really important to actually take a step back and decide how you want to proceed. You really need to keep the child at the center, and it's useful to actually get your team together to make sure that we decide how we keep the child's safety in mind. Yes, we do need a diagnosis, we need to get our biopsies, but if we were to go in with us that we need a bone marrow biopsy, we kind of put the child in a prone position, that might just cause an upper airway obstruction, which will be absolutely a disaster. So Manas, so we talked about what the problems were, how this things is, and what things we need to be careful not to do. But we still need to make a diagnosis. We still need to know what's happening to this child. So faced with this situation where you have a child with a high white cell count, who's severely anemic, who's thrombocytopenic, possibly has an upper airway obstruction, possibly has a mediastinal mass, and we don't really want to make him lie down. We don't really want to take him and give him sedation for a CT scan. How would you proceed to make a diagnosis?
So in a situation like this, when you have a child who has an anterior mediastinal mass and you are suspecting acute leukemia based on the high white cell count, the diagnosis has to be made with the least invasive process. And here in this particular situation, the least invasive method would be to make a diagnosis from the peripheral blood. So you have 1,13,000 white cells sitting in your peripheral blood. Just take that sample, give it to your hematologist. They will do a flow cytometry on this, and they'll be able to tell you whether it is a B cell leukemia, a T cell leukemia, and you'll be able to differentiate that based on the immunophenotyping on the peripheral blood. You don't have to do a bone marrow in every leukemia. When you have very high white cell count, you can easily make a diagnosis from the peripheral blood. Even the molecular and the karyotype studies can be done on the peripheral blood. And in this situation, I would not like to risk the child by giving a sedation and doing an invasive bone marrow examination.
Thank you so much. I mean, that's one thing that we all want to stress to our pediatric colleagues out there, that if you have a case like this, where you have a very high peripheral white cell count, we really do not need to go for a bone marrow. Each and every test that we want can be done on the periphery. As Manas has said, we can do a flow cytometry to kind of quantify what kind of a leukemia it is. We can run our genetics test on it. Manas, if I might ask you another question, suppose we are faced with a slightly different case where you have a child, similar child coming in with signs of an upper airway obstruction, but with a normalish looking white cell count. So which means it doesn't look like it's a leukemia, but just with a mediastinal mass, but you still need a diagnosis. How would you proceed in something like that?
So if you have a child with a mediastinal superior mediastinal syndrome, so there are two different entities. So superior vena cava is when your vena cava is getting compressed and there is congestion. Superior mediastinum is when your trachea is getting compressed. Now this is a real medical emergency because this child can die in the next few hours. So this is something we have to act very fast. If this child was in a periphery, not in an oncology center where all the facilities are available, I might just empirically start this child on steroids to save the life of this child in discussion with an oncologist. But if we are in a setting where we are able to manage invasive tests and make a diagnosis, we would look at if there is a pleural effusion or not. If there is a pleural effusion, I will tap the pleural fluid. The pleural fluid will have malignant cells. We can make a block out of those malignant cells, and with that cell block, we can do a immunophenotyping and we can come to a conclusion whether it is a T cell, B cell, or what kind of a leukemia, lymphoma it is. If
Thank you.
suppose you do not have a pleural effusion and you have a white cell count which is normal, rather than going ahead and doing a mediastinal node biopsy, I would look for some peripheral nodes.
Absolutely.
If I find some nodes, say in the neck, in axilla, wherever, I might just do a biopsy from those nodes and subject that to immunohistochemistry, and that will give me a diagnosis. However, if there are no nodes, no fluid, white cell count is normal, in that particular situation, I might have to do an awake bone marrow of that child and not give sedation to get some cells and make a diagnosis, or probably empirically give steroids in case the child is very, very sick. The last resort would be to do a mediastinal node biopsy, which is an invasive procedure, and we want to avoid it as much as possible.
Thanks, Max. So carrying on, we looked at it, we saw what the complete blood count had showed, cytopenia, and we had seen blast, we seen the platelet count. So we did the arterial blood gas, we looked at the renal functions, uric acid, and an LDH.
Dr. Shantanu, I think your voice is little low.
Oh, I'm so sorry. Is
Yeah.
this better?
Yeah, better.
So this is what Manas has already actually covered very, very effectively, that we do. I mean, yes, we might think of doing a bone marrow aspiration and biopsy, but that really is not needed in all cases. And many a time we can get all our answers by looking either at a peripheral lymph node or peripheral white cell count and doing a flow on that. We can look at doing a pleural fluid cytology, and only if everything is helpful, only then we'll think about whether we need to do a mass biopsy, but that too would be, as he said, awake with full precautions. So investigations, as we said, that supine position is hazardous. Most investigations we really need to do in a sitting position, not even lateral. I would just say sitting position with proper sedation, it can be done. We really, don't want to get a CT scan in these patients, but if we have to do, we really have to make sure that our anesthetic colleagues are ready. But even for them, the job might be very difficult because sometimes it's almost impossible to intubate these kids. So we have a blood film here. Ruchira, I don't know if you're here. Would you like to comment on this?
So the peripheral smear that's showing us large cells that are blue, which typically are what we call blast cells. You can see that they're very large cells with a very large nucleus, and in the middle of these, you can also see the nucleoli in them. They are much bigger as compared to the red blood cells that we see. So this would be what we would call a lymphoblast on the peripheral smear, and this kind of confirms the diagnosis that this would be an acute lymphoblastic leukemia. To confirm which type of leukemia it is, we would need the help of flow for these patients generally.
Thank you so much. So as we said that this patient has come in with subconjunctival hemorrhage and severe anemia. So we decide to give some blood. So what precautions do we need to take while transfusing blood products to such a patient?
So again, what we notice is that the child has a very high white cell count. For platelet transfusions, the first thing I would like to stress is that a subconjunctival hemorrhage is actually not a dangerous bleed for us. It's a mucosal bleed, what we would say, submucosal bleed, and it's not dangerous. The ones that we would be watching out for are mucosal bleeds. So if you have a wet hematoma in your mouth, or you're bleeding in your gut, or while the child is vomiting his blood-stained vomit or blood-stained cough, that's what is dangerous for us. However, this child has a mediastinal mass, has a very high white cell count, and therefore is likely to have CNS symptoms also because of what is called hyperviscosity, or may even have lung symptoms as in terms of respiratory distress. So what the child would need is very good hydration, making sure that the child is not in cardiac failure. For platelet transfusions, if the child has got a fever, then we like to keep the platelet count above 20,000. And that's generally what is recommended. For blood transfusions, we would like to avoid blood transfusions because it will increase the hyperviscosity, and therefore not recommended. If the child is in cardiac failure, would recommend very slow and low volume transfusions, if at all, just in order to stabilize the patient, to try and avoid as much as possible.
So that's what I wanted to kind of like to stress, that even if your child is anemic in a situation like this, we really have to be careful not to give too much transfusions to the child, because they might actually, they will not be able to tolerate it. So my next question is that we have a patient who's got mediastinal widening. Now, what possible, this is, I think my colleague, Dr. Ganesh Jaishatkar is also here with us on the panel. What are the possible malignancies that are there which can present with a mediastinal mass, and how can we make a differential diagnosis between them? Dr. Jaishatkar, Ganesh?
Shantanu, he may not be accessible.
All right, okay.
The questions you can probably.
In that case, can I go back to Vikas in that case, or anybody can take this question?
All right. So as this case is a case of leukemia, and probably there is a lymphomatous mass. So in this case, it's an anterior mediastinal mass. So the differentials of anterior mediastinal mass would be a lymphoma. It can be a thymoma. It can be a germ cell tumor, and rarely Langerhans cell histiocytosis (LCH) can also present like a anterior mediastinal mass. So these are the malignant conditions, and LCH is also is one of the condition which can present as an anterior mediastinal mass. And definitely then among the non-malignant thymic infections, thymic masses, parathyroid adenomas are also there, which can come in the anterior mediastinum. In the middle mediastinum, you can have leukemias, lymphomas, infections, bronchogenic cysts, thyroid masses, cystic hygomas, which can come from the middle mediastinum. And if we talk about the posterior mediastinum, then the most common differential for us is a neuroblastoma, but it can be a neuroenteric cyst, or sometimes a PNET or a E-wings can also arise from a posterior mediastinum.
Thanks, Vikas. Just 1 second, sorry. So we actually kind of touched on this already. I'll just continue on. I would rather, sorry, it's against coming to Vikas. So we've done a biochemical evaluation which shows that the creatinine is 1, which is high for this age. We got a high serum potassium, low calcium, high phosphate, and uric acid is also high. So what's going on out here, Vikas? What's happening?
So as it's a case of acute leukemia, and probably the diagnosis is T-cell acute lymphoblastic leukemia in this case. So right now this child is in tumor lysis syndrome, which is another emergency. So we would like to stabilize this child by giving hyperhydration, as the uric acid might also rise. Then you may need to start this patient on allopurinol. The potassium level is high. You have to give Lasix in this case, and then you have to monitor the blood. You need to monitor the biochemical parameters, and depending on that, you may have to act.
Thanks. So basically, this is one of our major medical emergencies that we face in pediatrics, that we will lose patients if we don't identify patients that are going into tumor lysis early, and we have to be careful to manage that. I'm not going to go into the management too much. I have a question for Stalin here. Stalin, would you give antibiotics to this child, and what would be your choice?
Okay, so even though traditionally we describe neutropenia as less than 0.5 or less than 500 absolute neutrophil count, if this child has got fever, the fever could be due to leukemia itself, or can be due to some infection. But in this scenario, even though the white cell count is high, most of them are going to be blasts, and the actual real functional neutrophils are going to be low. So if the child has fever, we need to treat it with antibiotics, and any antibiotics which will have a gram-negative cover is what is important. So piperacillin tazobactam combination would be a good one to start. But before starting antibiotics, we definitely have to take cultures, because if the cultures are negative and the inflammatory markers are low, later on we can stop it.
So, but this child is not actually neutropenic. So why would we think that this is treat this child as a febrile neutropenic patient?
Because this, now we are going to start treatment. The treatment is going to involve steroids, and so if there is fever, it is better to be err on the safer side of starting the antibiotics, and then later on we can withdraw it if there is no proof of infection.
Can I ask Ruchira to tell us very briefly how ALL patients are treated, and then we'll go on to the next case because I really want to go to the next scenario.
So pediatric ALLs, the treatment for pediatric ALLs is a bit different from adult ALLs. We, as pediatric oncologists, are a bit more aggressive in our management of our patients. The common protocols that we follow generally divide the treatment into 4 different arms, covering a span of about 2 years, 2.5 years. The first one is what we call an induction arm, where we treat with about 4 drugs or 3 drugs, depending on how we risk stratify our patients. And risk stratification becomes important for pediatric ALLs because depending on your age, your sex, the type of leukemia you have, your white cell count and presentation, and your response to therapy, we will be able to risk stratify and decrease or increase the treatment, putting you either into standard risk or high risk or intermediate risk arms. The induction arm lasts for about a month. Generally, is about 28 to 32 days, depending on the protocol that you're following. And what we say that we will risk assessment will be done at day 8, and then either at day 15, but most importantly at day 33, which is the end of induction.
So basically what we want to say is that the way we treat pediatrics and adults is actually different, and actually Gaurav has touched upon this already, sir. So which means that we actually treat our pediatric patients much more aggressively, and that's actually what we see in our outcomes as well. So when we talk about pediatric, correct, yes. Our survival figures are much better. I want to quickly go into shared care practice for a second, and this is for Manas, please. So you've received a phone call from a pediatrician practicing in a small center quite a long distance away, and they have been seeing a child with reluctance to walk, joint pains, been prescribed with ibuprofen, paracetamol, and found that he's some petechial rash. Found a very similar case, low hemoglobin, high white cells, low platelets. So he's worried, he wants to send the patient to you straight away. And this is something that comes to us very often. How would you deal with this? Would you say, fine, get him onto a car and send him to me straight away? What would you do?
So you know, shared care in practice is very important. Pediatric oncology pediatric oncologists alone cannot win all the battles. We need our pediatricians to work with us, and their help to us is, you know, of paramount importance, especially in early diagnosis of cancer. So this is a case where there is high white cell count, low platelets, low hemoglobin. So clearly all 3 cell lines are involved. We are most likely dealing with a leukemia. I would first of all stop the ibuprofen for this child because he's very severely thrombocytopenic, and that makes the platelet dysfunctional. I would probably start the child on some fluids because, again, you know, tumor lysis is a possibility. This child can go into hyperviscosity if he has AML or if he has T-cell ALL. So I want to give this child some fluids. If he has high-grade fever, I may want to give a shot of an IV antibiotic and then refer the child if we do not have availability of platelets. However, if we have availability of platelets in our center, I would probably also give platelets to this child and then refer the child for further treatment. On that note, I would also like to mention, when we were talking about the tumor lysis aspect, you know, do not give KCl in the fluids. That's a very important thing for all the pediatricians because there is hyperkalemia. Avoid coconut water because, you know, there is a tendency of giving lots and lots of coconut water if a child is sick. So these are 2 common things that we can do to avoid hyperkalemia in these situations. Avoid steroids because if you give steroids, your cells may lyse and make the diagnosis difficult, make the management difficult, and precipitate tumor lysis if we are not giving adequate fluids. So these would be my recommendations. Talk to your oncologist, get him into confidence, and both of you discuss the situation and send the child when he's relatively stable.
Thank you. Thank you so much indeed. Vikas, would you comment on what do you actually mean by the shared care model of practicing and managing pediatric cancers?
Yeah, sure. So I think Manas has nicely touched on this. So we need to understand that without the help of the pediatricians, it would be very difficult to manage these patients because these are the primary caregivers who actually treat these patients and actually make a diagnosis and then send these patients to a correct center. So they need to the pediatricians needs to be trained how to diagnose common pediatric malignancies like leukemias, brain tumors, and other solid tumors what we all see in our day-to-day practice, so that they can make a correct diagnosis, and then they can communicate with us, and then if there is a need to refer this patient, they can be referred in a stabilized way. Then when you are continuing with the chemotherapy for these patients, and in between if the patient wants to go back to the hometown, these doctors needs to be trained the do's and don'ts for these kids, because in case the patient develops a fever, is neutropenic, the counts are low, needs IV antibiotics, that can be done at the hometown, that can be done by the general pediatrician who was actually managing this patient. And once the treatment is finished, these pediatricians can manage, in the sense that in the post completion phase, they can do monthly blood counts for leukemia patients, they can vaccinate these patients after the completion of chemotherapy. I think that's what is what we understand with shared care, and that's what the pediatricians also need to understand.
So this is basically a partnership. So we cannot actually treat these kids in isolation in our central hospitals. So all of our patients, basically, we need to build bridges. We have to manage them together rather than treating them in our isolation. We need to talk. So it's all about communicating. It's all about working together in order to achieve the good outcomes that we want for our patients. Now, this question is for Stalin. He wants to know, the GP phones up saying that the vaccines that are needed to protect the child, do we need to continue with all these vaccinations from a young child during chemotherapy? How would you advise a colleague at the end of the phone asking about this question?
Yes, during the treatment with chemotherapy, the response to the vaccination is not going to be that great. So generally, we don't advise or give regular vaccinations, because all this needs to be caught up after the end of the chemotherapy. But there are certain vaccinations like flu vaccination is advised.
Correct. So that was going to be my next question. So specifically, Manas, will you talk to me about two vaccines specifically? One is flu, and if you could touch upon oral polio, please.
Sorry, I missed your question, but I can read it.
Hello,
so
can you hear me?
It's about the vaccines that can be given during active chemotherapy. So one is, I think we can give the flu vaccine to the child during the chemotherapy. The other thing is that if the child is not immunized, we may have to give hepatitis B vaccine, because we are going to use blood and blood products. But nowadays, most of the patients are immunized. So most of the time during active chemotherapy, we do not give any vaccination, and we just give it at the end of treatment. Even if we have to give, killed vaccines can safely be given.
Stalin, I've got one more question for you. Sorry, at some point you just, we couldn't hear you. Suppose we have a young child that is being treated for a cancer, and there's a sibling. Is there anything specific you'd advise the GP about the vaccinations for the sibling? So what I'm specifically looking at is advice regarding polio vaccination. Stalin, I'm sorry.
I think Manas can take it.
Manas, would you take that question, please?
So I think we need to avoid the oral polio vaccine for the siblings. We can give the injectable polio. So we want to avoid live vaccines in the family members or the people who are coming close to the child, but we can administer killed vaccines.
Correct. That's a very important point when we are treating young kids with cancers, that other siblings at home at the same place, we really did them. I mean, specifically, we don't want them to have a live vaccine, and the most important ones to actually avoid is an oral polio in that situation. Because as you know, the way of developing an immunity to polio is that you actually supposed to excrete it in your stools. And certainly if you have a patient who's immunosuppressed because of chemotherapy, giving a sibling oral polio at the same house is not something that you would suggest. So this question again, I think is going back to whoever wants to take it, that we
Dr. Shantanu, I think Stalin has messaged, is the problem with laptop, he will
rejoin.
once again rejoin. That's what his message.
All right. Okay. So this is open. So basically, this is asking about revaccinations, and happy for anybody to answer this, that basically what vaccinations do we need to give to our patients after they finish chemotherapy, and what vaccinations do we need to give them after after they have had a BMT?
So Shantanu, if we are talking about vaccination after ALL, we mainly need to give the booster vaccines. We
Correct.
don't give the entire vaccination program. We usually start 6 months after completion of ALL therapy, and we mainly give booster vaccines.
Absolutely.
And that too, if a child is more than 5 years, we usually avoid vaccines like IPV, Hib. They are not really necessary. Whereas BMT is a different ball game. When we talk about BMT, the immune system has been completely wiped out. And in these patients, we start vaccination usually after 1 year. And we have to give the entire vaccination protocol once again to give the immunity to the child. So I would do that in discussion and as per the recommendations which are there for vaccinating immunocompromised patients. And there are definite guidelines which are available online.
Correct. So this basically means that this was again for Ruchira, because Ruchira, these are the patients that you would be transplanting fairly often. And so basically, how would you?
We also would need to keep in mind whether this child has received rituximab, because that would also affect the immune reconstitution. So we would not want to revaccinate them very quickly after receiving rituximab. So generally we'll wait for at least 6 months before we do that. And also if a child would like to measure their immune reconstitution before we start vaccinations for all our bone marrow transplant patients. A lot of these patients may actually be on immunosuppressive therapy even about a year post-transplant, and they would still not be eligible for vaccinations at that stage.
So that's what I wanted to stress, that just because 6 months of follow-up doesn't mean automatically we start vaccinations, as Ruchira very correctly said. We need to see what the immune reconstitution is. Ruchira, if you have given them immunoglobulin post-transplant, would that affect your decision to start vaccinations for these children?
So if you're needing a lot of immunoglobulin therapy, repeated immunoglobulin therapy, that means that their immune reconstitution is not good. So I would still wait. I generally would wait for at least 3 months before the last IVIG therapy before I plan for vaccination for these patients.
I'm just going to carry on to the next
Dr.
section.
Shantanu, if you could take the cord blood banking now.
Correct.
Quickly.
So that's what I'm just going to go into straight away. And we all kind of know what cord blood banking is. That way we collect the cord blood from the children, from the babies immediately after birth, and then it is stored in a cord bank to be used later on. But the reason we want to talk about it, because this is a topic that actually creates a lot of controversies, and we talk about it in a managed fashion. Because what are the benefits? Why do we have cord blood banks? Because you're...
Yeah, I can. Can you hear me?
Yeah, we can.
All right. So I think all the pediatricians who are listening to us, they need to understand that there are two types of cord blood banks. One is a public bank and another one is a private bank. So when we talk about cord blood banking...
I think Stalin is taking the public and the private question. So, but basically, why do we have cord banks? What are the benefits?
So we need to understand that if you have a cord blood bank and somebody in your family needs a transplant, urgent transplant, and you have a cord blood unit preserved for the sibling of that patient, then you can get the cord blood unit, and with that you can do a transplant. So it's a I would say, an easier way of doing a stem cell transplant. There are pros and cons of doing a cord blood transplant. I think that Stalin might be able to answer.
I think Shantanu, Stalin is not joined yet again.
Yes, sorry, I'm here. Can you hear me?
Yeah, you said, yeah.
Yeah,
Stalin, please go ahead.
Yes. So there is a difference between public cord blood banking and the private cord blood banking. So when we say public, the donor or the parents consent for the cord blood collection, and usually they don't pay for it, because the it is collected in public interest and it is stored, and whoever is a match later on comes to match for this particular cord blood which is stored, it will be donated and it can be used by anybody. Whereas in private cord blood banking, it is the cord blood collection is owned by the family. They generally have to pay for it, for the collection, as well as for annual fee for maintenance of it as well. And most of the time it is done with the idea that this cord blood is going to be used for their family. And so that is that is the main difference between private cord blood bank and the public cord blood bank. In general, it is the public cord blood bank which is good, because then you have a lot of collection which then can be used for anybody. It is like blood donation. You donate blood not for yourself or your family members, but for generally to be used by somebody else. Whereas the chances of the cord blood which is stored in a private blood bank being used is very, very low. They have told somewhere between 1 in 10,000 to 1 in 2 to 1 million or something like that. So that is a realistic chance of it being used, because most of the conditions where we do transplant for either a leukemia or a genetic inherited genetic conditions, metabolic conditions, all of those things we cannot use the patient's own cord blood.
Right.
So the only situation where families can consider using the private cord blood bank is that if there is already a genetic disease existing in the family, and that is only the situation where they can consider weighing the pros and cons, because even otherwise you have the other sibling with you to use it later on. So that will be, so some of the countries have actually, even countries like France and Italy have legally banned the private cord blood banking. So we are not in that situation in our country, but family has to understand the usage before they are consent for a private cord blood banking.
Thank you so much, Stalin. So basically, if we have a public cord bank that is available for anybody who needs to have a stem cell transplant, whereas the private cord banks are basically only for individual use. And I also agree with you that it can't really be helped. It's not a very useful thing to do. Manas, we've been seeing a lot of marketing and promotional activities which are being directed by these cord blood banks, and they are kind of focused towards our gynecological colleagues and even more towards women at a very state, at a very vulnerable state of their pregnancies, where they are absolutely hammered by all promotional activities. What do you think is happening out here? What's your opinion about it?
So Shantanu, I don't know if you can listen to me, but I lost your voice. So yeah, so it's basically same as you watch a cartoon channel. A kid is watching a cartoon channel, and all he can see is the advertisements of chips, chocolates, all the junk food, and everything that he is going to get tempted to. So a mother who is pregnant, a lady who is pregnant, is all hormonal, is emotionally extremely fragile, and these are the target population whom all these private companies target and want them to buy something for their unborn child, which probably is never going to be used for that baby. So this is, I would say, in my hematology, oncology language, criminal. It should not be done. It's targeting emotionally fragile people to invest into something which is wrong. In a country where we don't have 100% vaccination, if somebody's spending 75,000 to 1 lakh to a cord blood bank, which he or she is never going to use, I think this is something wrong.
Thank you so much, Manas. I think you kind of like voiced a thing that we all feel very much in our hearts. Ruchira, if you take the other view, is there a role for cord blanks in today's greater transplant world per se?
So cord blood banking is a very good source for stem cell transplants for pediatrics, not for adults, but pediatrics, because it's a ready source of stem cells that is available if we need it. But that is from public cord blood banks that we get this from. So there is still a role. With haploidentical transplants coming into play, the role of cord blood transplant is decreasing, but I wouldn't say that it has gone away completely. So public cord blood transplant still has a big role.
Thank you. Thank you so much. Sorry. Again, this was for Arpita, but actually I went on the net yesterday, and this is from an unnamed cord blood bank, and I actually looked what they said. They said that why do other banks store cells? Why don't other banks store cells that are extracted from placenta, amniotic sac, and amniotic fluid? And it's because other banks, they lack the technological know-how that's required to process them. And as a result, the parents are left uninformed, which results in these valuable sources of stem cells being disposed of as biological waste. And they went on to say that they are the only ones that they can do this. Up to the group, what do you think about this comment that has been made and put in the public space?
So I'll make a comment on that. So generally, the way cord blood is collected is after the umbilical cord is cut after the delivery of the child. Whatever extra blood that remains in the placenta, that is kind of milked out and collected. So it's a volume of just about 30 to 40 ml at the maximum. There's no amniotic sac or amniotic fluid involved. This is blood in the placenta. So that's completely wrong what they've commented on. It's a very small volume of blood, but it's a very, very high source of stem cells in it. That's
May
it.
intervene,
Yep.
Shantanu, just I think we have to conclude also. See, I think just to put the things in perspective and what this means, this paragraph here, and for all, you know, for all the audience who's listening, the cord blood banking has taken a different shape or different direction now.
In
It's
India.
not only cord blood banking, it's also what they call as cord tissue banking.
Correct.
Okay? And that cord tissue is coming from placenta, from amniotic sac, from Wharton jelly, from all these things. And what they claim and what they do from that is something called as mesenchymal stem cell extraction. So they are trying to tell you that they are going to store not only blood stem cells, but they are also going to store mesenchymal stem cells for you. And the use of mesenchymal stem cells, again, you know, it's a parallel world altogether, where they claim that mesenchymal stem cells are a treatment for everything. So just for our colleagues here, you know, is that one, I think what we try to say is that private cord blanking is something which is not recommended by any professional body, and we don't recommend either. There's an IAP, we have done a position statement or a guideline on it, which is published in Indian Pediatrics a couple of years ago, that can be referred to. And the second is, you know, that these mesenchymal stem cells have got no role at all, because you can use anybody's mesenchymal stem cells. You don't necessarily use your own child's mesenchymal stem cell, if at all they need to be used for something in the future. And the third important aspect also we need to also tell the audience is that unfortunately in India, there is no functional public cord blood bank at this point of time. There used to be Reliance and Jeevan cord blood bank, but they are no longer existent now, functional now. They are there, but they are not functional. So, you know, having said that, although, you know, we are recommending public cord banks, not available at this point of time for Indians. So there's a middle path which has been adopted by some of the private cord blood banks, and that's called as community banking. That means you store a cord blood in the cord blood bank, and all the units in that cord blood bank become a property or access to all the members who have deposited cord blood in the cord blood bank. For example, there are 5 lakh families who have stored their cord blood bank in a particular blood bank, particular cord blood bank. All these 5 lakh people have got access to anybody's cord blood in that bank, which is probably a step forward. It's not as good as complete public cord blood banking, but I think probably a step forward in the right direction, I would say.
Getting where we want them to go, really. I just want to say that, I mean, even if you look at cord blood banking, there's a lot of wrong information out there. And parents can easily be swayed by all of these things, that there's claims that it will treat type 1 diabetes, congenital heart disease, autism, cerebral palsy. It's very important to actually understand that the role of collecting cord stem cells really is with hematopoietic stem cells to deal with leukemias, lymphomas, and various conditions. If somebody is trying to persuade that this can be used to treat autism, cerebral palsy, please don't believe them. That will only be in terms of advanced trials somewhere. For general use, it's not really something that we can do. And I'll just finish with this question, because all of us get these questions from our colleagues often, because we all stay and we work in our own little worlds. If a friend calls up to say that he's going to have a baby and he's being persuaded that he needs to go in for cord cell banking, in today's world, what would you say? What would you tell them?
I think I would generally discourage anybody from going for cord blood banking. But at the end of the day, we cannot force our views, but anybody who is taking a decision have to fully understand what is the chances of being it utilized and how much money they are spending. That is a very, very important call. Of course, if they have a genetic disease in the family, then I would advise that it would be a reasonable thing to do, but otherwise it is not advised.
I think we've talked about what the status is today, and I think you've touched upon that, which are the patients. So because any patients in whom you definitely ask the parents to go in for cord blood banking?
Okay, so if you have a genetic problem in the family, or if you have a patient who's having leukemia and the mother is expecting, then you can consider getting a cord blood banking done at that point of time.
Thank you. I think I've run over my time considerably, but when you have a panel which is so well informed and it's a good discussion to have, so I hope I'll be excused for doing that. I thank you all for joining me, and over to you, Sunil, once again.
Thank you very much, Shantanu. I think it was a lovely interaction, and I would have loved you to continue forever, I think, and I think I'm pretty sure our audience would have liked the discussions as well. I think we'll conclude. There are a couple of questions in the chat box which we need to answer, and I think there was one question which was on which combination chelation which we use for cardiac iron overload and LV dysfunction. I think I tried to answer that. It's Dr. Varun who has asked this question briefly in my presentation. So Calfer or deferprone is considered kind of the best iron chelator for cardiac iron overload. And if you have to use a combination, the maximum data is there for desferoxamine, which is Desferal, and deferprone, which is Calfer. So you can use these two together. What's also recommended is that a longer IV chelation with Desferal, which may be a 24-hour infusion, may be better than giving subcutaneous for shorter durations if there's a cardiac dysfunction already there. So that is something which you can use. The second question is from Alka, and she's asking experience with Thaldomite plus hydroxyurea. So Dr. Alka, Thaldomite is, as I showed in that list, is also a molecule which is used as a fetal hemoglobin inducer, or the gamma chain inducer, and can help in this what you call as disproportionation between alpha and beta chains, and help in increase the hemoglobin levels. But having said that, Thaldomite is a very toxic drug. It has been refurbished basically for multiple myeloma in adults. You already know that it was out of use for many decades because of its teratogenic effect and effects in pregnant ladies. So when you use this drug in children, and that for long duration of time, we don't have enough data for that. It has been tried in a very select group of patients. For example, those who develop allosensitization to red cells, and you cannot really transfuse them blood because they're allosensitized. In that group of patients has been used. It's probably a good fetal hemoglobin inducer, but I think we need a lot of data. It's being used left, right, and center at this point of time, but I think it has to be done in a clinical trial setting in a good study, and the feasibility and safety for a long duration of time in children has to be assessed before it becomes kind of readily used and readily available to be used in children. So that was, I think, a question on the Thaldomite. So I think that's what we have in the chat box. Any other questions if we have? If
No,
not, Dr. Ravi Shankar.
No, I didn't say anything. I didn't say anything.
Okay.
Only intels are telling fantastic.
Okay.
JP Tandon from Moradabad commented excellent discussion with learned panelists. So some good messages. No brickbats, only buckets are there. Everyone take. Each can take
Right.
1 or 2 to.
So thank you.
So,
thank you very much, Dr. Ravi Shankar, for giving the opportunity from all of us from the Hematology Oncology fraternity for giving this opportunity to us, and we'll try to love to engage with you many more times and discuss topics which are relevant in day-to-day practice. Over to you, sir.
Thank you.
Yeah, no, nothing. I mean, it's a fantastic discussion. Everybody gave a good knowledge to us, to our general pediatricians, what to do, what not to do, and good case discussion. It was a really good. That is a good idea, Sunil. So sometimes we'll get an emergency, even in the district centers or like that one. So when they get a case like the serious case, what they are supposed to do. So, and steroids was a good suggestion. I didn't know that steroids. I was always hesitant to give steroids anytime. Whenever cases come, I was always afraid. So it is a good thing. Nice discussion. So from Uttarakhand to Rohtak to Telangana to Tumkur, everybody listened to you. So nice of you.
Thank you very much. And I think we should, before we conclude, thank MCure for getting us all together. I think their effort for the last few weeks. And Keyur, you please conclude the meeting, and then I think we'll break for dinner, which is again MCure, what do you call that?
Dinner in your own home.
Now all dinners are digital dinners, sir.
It's Keyur using Zomato to send us dinner. That would be lovely.
Next time onwards, we'll try something, sir. I want to thank you each and every speaker, panelist, chairperson, and Dr. Ravi Shankar and Dr. Sunil, who has thought about this wonderful program and give us the opportunity to associate with you. It is a truly scientific event where MCure is presenting themselves. And thank you for giving opportunity to MCure also for this kind of program, sir. And in future also, we will try to associate as maximum as possible from our end with the Pediatric Association of India, sir. And thank you so much for giving your valuable time and expert opinion for this meeting, sir. Thank you so much. Thank you.
Thank you. Thank you a lot.
Thank you very much. Thank you,
Thanks once
everyone, and
again
have
to
a good
MQ.
evening.
Thank you, sir.